Let's go to the beginning of the video. Go to the very, very beginning of the video, like 001 seconds, and then hit play. Now hit play, we're done. Awesome. So I'm talking, obviously, my favorite topic ever is challenging cataract cases. You can hit play on the video. Hit the play button and then just don't touch it no matter what. Did you hit the play button? No. You need to hit the play button on the video. There we go, now we're talking. So I love challenging cataract cases. That's my favorite thing. And so the first one I'm talking about is a complication. So I was talking to a surgeon yesterday, a very experienced surgeon who's done 100,000 cases. And we both agreed that sometimes you just can't predict a complication. So I'm going to show you in a case here. In fact, you know what? We're going to speed up my video. Can we do 2x for the video? So we're getting the rexes done here. It looks like a routine case. But it's important that we learn from every case. And so one of the most important principles is recording every surgery you do, because you never know when you're going to hit a complication. Hey, audio video, can you do 2x speed on this? So here's a routine case. This is a Beverly Hills type cataract, not too dense. I know my Indian colleagues say, where's the cataract when I show a case like this? But you'll see it's a lot of posterior subcapsular cataract. There we go. Here are the young doctors. Come on in. And so at the end of the case here, you'll see it looks pretty routine. And we have a very high volume surgery center. Our surgery center in Beverly Hills does about 20,000 cataracts a year total with all surgeons combined. So we obviously are very efficient at surgery. Did you figure out 2x? Hey, my friend, did you figure out 2x, how to speed up the video? And so here's the case where, watch carefully, you'll see that's not what we wanted. Okay. Well, in this case here, let me show you where I have a complication. The complication comes when we're aspirating here. We can take out the cortex, and then you'll see in the posterior capsule, you haven't figured it out, right? You don't know how to do 2x? I can teach you, but then I'll have to take your salary. So watch carefully as I take out this last little bit of cortex here, and we would all do this. We'd go there and look at the posterior capsule, that one little tiny fragment of lens material which I'd like to aspirate. And as I go to aspirate it, watch carefully, I think I'm just gonna get that one little piece here, and as we do so, the capsule opens up. So what do you do now, right? Well, the key is how to react to a complication. We all have complications. So watch carefully, there's nothing I could have done here. Aspirating this little tiny tag, this is at 1/4 speed, and as I go to grab it, you'll notice right there, boom, capsule's open. Now what? Well, the key is obviously to react appropriately. So stay in the eye position 1, keep the infusion on, and now inject some viscoelastic. Well, I can keep the anterior hyaloid face intact. This patient will have 0 vitreous prolapse. So there's the viscoelastic going in here, keeping the eye pressurized. Don't let the AC pressure go to 0. You want to be able to prevent vitreous prolapse. And now what can you do? Well, I have a totally intact anterior hyaloid face here. So I'll put a little more viscoelastic. Well, why don't we put a 3-piece lens in? I've got a beautiful capsular rexus. And so what we're going to do here is just slightly enlarge the incision to allow us to easily place a 3-piece lens. Now, a mistake that I would have made in the past would be to try shove the 3-piece lens through the smaller incision. At this point, I know better. Just slightly enlarge the incision so you can be as gentle as possible. Even in this case with an open posterior capsule, I'm telling you the anterior hyaloid face is intact. And we'll be able to get a 3-piece lens with haptics in the sulcus and optic captured and have a beautiful refractive and visual outcome the next day. This patient was absolutely spot on target, 6/6 vision the next morning. So here I'm just using my diamond keratome to slightly enlarge the incisions. I'm in Beverly Hills, so I like diamonds, so I'm fancy. That's a joke. And so here comes the lens. Now, when you put the 3-piece lens in the eye, you have to go back to your simple concepts of the 7L rule, right? I always teach on Cataract Coach, the leading haptic better look like a number 7. There it is. And then the optic comes out, and the trailing haptic like the capital letter L. That's the 7L rule. So, right, the eye wall haptic should not look like an S. If they look like the letter S, I'm making a stupid mistake, so I don't want that. So there you go, optic captured behind the rexus. And you have a beautiful outcome here. Notice here at the end, I'm going to hydrate up the incisions. just to make sure. Why do I want to hydrate the incision before removing viscoelastic? Well, as I take out the viscoelastic and come out of the eye, I don't want the AC to shallow or collapse. Right now, the vitreous is intact, the anterior phase is intact, there's zero vitreous prolapse. I want to keep it that way. And then I just think of the good part. This patient's never going to need a YAG laser capsulotomy. So think of the good thing there. And so we'll finish up the case here. I'm going to get through this a little faster for the benefit of time here. But you can see we'll finish up the case and the outcome's pretty nice. And then let's do this. Let's fast forward here. I'm going to show you a different case. Let's fast forward to something that's more complicated. So we also have to learn new techniques. We can't shy away from that. So what I mean by that is here. Here's a patient who's going to get Gore-Tex IOL fixation. This is a patient who came in, and you can see, if I use the traditional way of Gore-Tex, it's under the conj, it's above the sclera. That's terrible. That's going to erode away with time. And you can see patients like this where the Gore-Tex has eroded away. You just can't leave it under the conjunctiva. So in a case like this, what we're going to do is we're going to pass intrascleral Gore-Tex. This is that 8.0 Gore-Tex on the CV8 needle. And so as we pass it, this is only going through the sclera. So from one potential sclerotomy site to the other, between the two sites, we have a pass of Gore-Tex. Now we can enter in and bring it out the incision, and you'll see, here we go. And in this case, we had to do a scleral tunnel and a larger incision because the patient had a PMMA AC IOL that we removed. So now you can see how we place the Gore-Tex, and I'll show you at the end here a diagram of exactly how to do it. But the key here is to be able to learn new techniques and not be complacent with what we're just doing from the base. No one taught me this in residency. This is just not taught anywhere. So you have to watch videos on your own and learn. That's why people love Cataract Coach. So I'll pull this through here, and you'll see we'll get the two ends in. We'll get the IOL. This is a 4-point IOL. There are many IOLs on the market here in India that have these 4 eyelets. And you can see now, look, we have both Gore-Tex sutures coming out of a single sclerotomy site. And as a result, when we tie this knot down nice and easy, we'll get the lens centered, and this will be permanent. The knot will be inside the eye. There will be zero visible Gore-Tex suture. So again, we're tying it up. Remember, the Gore-Tex is very slippery, so make sure the knots are tight and secure. Nice and tight. Leave the ends a little on the longer side. And do the same on the other side. There we go. And so this is a case where I taught one of the UCLA residents. I've since retired from my job at UCLA, and now I'm actually going to I'll start teaching the University of Iowa residents later this year. So there we go, rotating those sutures, sealing it up, and let me just show you how we did it. At the end here, we can remove the viscoelastic. Notice the knots of the Gore-Tex are placed within the sclera. And so again, finishing it up here, and I'll give you a diagram of exactly how to do this. So this is a technique that was pioneered by a New York surgeon named Jamin Brown, a retina surgeon. But again, a technique we can learn. So intrascleral past the Gore-Tex, here's the diagram. And so you get a tunnel, intrascleral tunnel with the Gore-Tex CV8 suture. And then once that suture is in place, again, we externalize it. You can see the yellow dotted line is the internal intrascleral pass of the Gore-Tex. And now we externalize it, place it through the IOL haptic loops, the eyelets, put the IOL inside the eye, and then once it's tied up, you'll see that's really secure. That lens has 4-point fixation. It'll never go anywhere. Gore-Tex lasts forever. And most importantly, there is no exposed Gore-Tex at all. So when you look at the side of the slit lamp 6 months or a year later, you have no idea how the eye was fixated, unless the patient, of course, dilates to a huge, 8 millimeters or so. At the end here, we can close up the conj and we can call it a day. And you can see there are 1, 2, 3 instruments here because this is me teaching a resident. So at the end of the case, it looks just fantastic, and patient had a beautiful outcome. And then for the very last thing I want to tell you is just be open to learning new things. Now, we were always taught how to do IOL exchange or cut the IOL inside the eye, fold it in the eye, but maybe there's another way. So here's a way where we can just actually twist it out of the eye. So grabbing the edge of the optic, so this is me operating, and I'll show you a resident case too, using a chopper here to get a better grasp. And notice I'm not grabbing the middle of the optic, the edge I want to grab. I have one haptic outside the eye. Now using the spatula to protect the cornea and help roll the lens, we respect that cornea. We don't want to touch the cornea. We can rotate our hand, pull it out of the eye, done. You can pull this out through a 2.2, 2.4 incision. I usually enlarge the 2.75 or 2.8, but you can pull the whole lens out intact. We published this paper long ago, although I'll tell you, Peer-reviewed is one thing, but if you want people to know about it, make a video. It's far, far better reach. So start with your hand supinated and you just pronate your hand. Here's a resident operating. So this is a resident doing this case, and you can see grabbing the edge of the optic there, using the spatula to protect the cornea. Of course, the AC is full of viscoelastic, so rotate. Let's get that spatula positioned. Rotate, 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 and you can just extract the whole lens very easily. And for the last few seconds of my talk, and I'm way ahead of schedule, which is great. Again, external view, look at that. It just rotates right out of the eye. So bottom line is just keep learning. That's the reason. I do Cataract Coach, a new video every day, because I want to learn. So thank you guys. 2,100 videos and counting. You can stop. We're done. All righty. Thank you guys. Any quick questions? We're a little ahead of schedule. Otherwise, I'll run to the session you arranged for me. All righty.
May I ask a question? We are all fans of Uday and Cataract Coach, and thanks a lot for giving us the Cataract Coach. About the twist and rotate, the forceps is a specially designed forceps?
No, anything. Straight tying forceps.
Straight tying forceps without any ridges on it?
No, just straight tying forceps. That's it. Cheap, cheap. Easy to do.
Wouldn't
Let me go, because she's going to take me to the next one. But the video's on